the new guidelines for selection of antiretroviral regimens for adults and adolescents who are post-pubertal with HIV. I apologize, I've been sick with a pretty bad cold, so I'm going to try to speak as clearly as I can, but if I'm mumbling or you guys can't hear me, just please interrupt me and let me know. So for overview and considerations, everything's pretty standard as far as changes, but always initiate ART as soon as possible, even if you have a patient with continued drug use. Therapy goals, of course, you want to raise and maintain a high CD4 count and reduce the viral load to an undetectable level. And for patients who are stabilized and virologically suppressed on an existing regimen, they don't necessarily need to be changed to the regimens that I'm about to talk about unless there's a compelling reason, such as adverse drug effects, or if, for instance, they're stabilized but not virologically suppressed, or if they're having issues with compliance or remembering medication, and there's a regimen that can simplify that issue. But on the whole, if they're stabilized and doing well, they don't necessarily need to be switched. These guidelines are more for if you have a patient who's maybe not had anything previously and you're wondering what of the 30 plus medications that are approved you should start them on. This is kind of a guideline for what to start. So some of the things that you want to consider are going to be pill burden, compliance issues, and dosing frequency. So if you have a patient that is particularly busy or has other things in life, maybe they're dealing with some drug issues or they're dealing with taking care of family members, you want to make sure the regimen is as simplified as possible. You want to make sure that you do resistance testing before you start, if at all possible. Drug disease state interaction potential and drug-drug interaction potential. So you want to try to get a complete drug list inclusive of any procedures that might affect how a patient metabolizes a drug, and we'll talk about that a little bit later. But you want to make sure you get a whole list of things that they're taking, that they're using maybe recreationally and being prescribed. So you always want to make sure you get a full list. Access and cost are super important because even if they can remember to take their medication, if they can't afford it, then they might take it every other day, and that's really going to be adversely affecting their health. So you want to make sure that you check with what insurance they have or what coupons are out there, or that they can afford the medication, because some people are just embarrassed to say, I can't afford my medication, so I only take it every other day. And then comorbidities are important as well, especially chronic kidney disease, Hep B, and Hep C. So there's 7 classes of medications used to treat HIV. Those are listed there, and I won't labor over those or read them out to you, but they're listed there for you. And there's about 30 medications that are within those, so it can be a little cumbersome to try to figure out what to start a new patient on, so that's why we'll go over some of the regimens. So these are the 4 regimens that have been recommended in the updated guidelines. So this was updated in July. They're actually looking for more updates at the end of 2019, but they made some significant adjustments. And what they were looking for when they made these recommendations was they did a comparison on virologic suppression. They looked at pill burden and how many times a day they would have to be taking the medication. And they also looked at tolerability and toxicity profiles. So that's kind of where they're coming from with these recommendations. And it's important to acknowledge who is putting out these recommendations. It's the Department of Health and Human Services panel on antiretroviral guidelines for adults and adolescents. And again, this does cover post-pubertal adolescents and adults. If you have a pre-pubertal adolescent or a child that you're treating, the sources page that I have is on the last slide is a good link. You can follow that and look at those regimens as well. So for those regimens, so they have some that were taken off for the dolutegravir, abacavir, and limifidine. So, yeah, sorry, we're going back to that. The abacavir, you always want to make sure that you do the testing for the HLA B5701 allele. And the reason for that is that this part of the population does have a pretty severe hypersensitivity reaction to that medication. And you always want to make sure you do that test before you start that medication, because that hypersensitivity reaction can emerge within the first 6 weeks of therapy. And you just want to make sure you check before you start that if you're going to select that particular regimen. They took the raltegravir regimens off. Now they do have more data than some of the ones that they added, but in head-to-head trials, they just looked and they have higher pill burden, which was the primary reason they were taken off. And then they also looked at efficacy too. So the raltegravir plus the tenofovir and emtricitabine was kept on, but some of the other ones were taken off. And for regimens 3 or 4, I didn't specify which tenofovir formulation because both of them are acceptable. But for the bictegravir, the first regimen, they did study it with the alphenamide formulation. So for the next slide, I've highlighted some testing prior to selection and initiation of treatment. This isn't all-inclusive of all the testing you're going to do before you start ART, but these are the tests that you're going to do that are going to be ones that are going to influence your choice of which ART to pick. So you, of course, want to do a pregnancy test because dolutegravir was in 2 of the 4 recommended regimens, and that you should not start, according to the guidelines right now, if they are pre-conception and not using appropriate birth control methods, or if they're within 12 weeks post-conception. They're doing a lot of studies on if it's safe after that, but for right now, if they are within that first trimester, or if they are someone who is at risk of pregnancy, they don't recommend that you start with a dolutegravir regimen. They don't have the adequate data to classify that as a class issue, but there are nerval tube defects that are associated with it, and it should be assumed at this time that it is a class issue. So they don't recommend that you start anything in that class if the patient is able to become pregnant or at risk of becoming pregnant. So just keep that in mind. They don't necessarily have the studies that say you can't, but it's not recommended because it is assumed that it's going to be something that affects the whole class. You want to do resistance testing. This is possible in most scenarios. If it's not, for instance, if you have a patient with a severe opportunistic infection, you have to start treatment right away. Dolutegravir is the one that the guidelines recommend that you start if you have to start something before you start resistance testing. And the reason for that is it has a higher barrier of resistance than the others. And we talked about the abacavir testing that you should do if you are considering that regimen. If you're considering a regimen with Maravira, you should always do the tropism testing. That's not one of the 4 regimens that we recommended, but there are regimens that they recommend for patients in certain situations. So if you're thinking of a regimen with that medication, you want to make sure you do that testing as well. Some of the other tests are the basic chemistry tests. You want to test their liver function. You want to do a CBC with differential. If they have chronic kidney disease, you want to make sure you're looking at their serum phosphorus levels. And on my last slide with the sources, if you have a patient with CKD that you're treating, if you look at source number 2, that's a really good in-depth source for some recommendations associated with that type of patient. I won't go too in-depth with it here, but if you have a patient and you need more information on that, that is a good source. You, of course, want to do a CD4 count and a viral load, and that's pretty standard, but you want to do it for selection of ART because there are some medications that you shouldn't start if the viral load is above a certain level. So that's why those are important. Hep B, serology, and Hep C screening are really important as well. So you want to do those before you start a regimen and before you start tweaking medications that they're on with hepatitis B especially. For alternative regimens, so usually your regimens are going to have an NRTI backbone of 2 medications, and then you're going to add something to that, usually an integrase strand inhibitor or an NRTI. But you want to have 2 NRTIs to start with. So what do you do when you can't use some of those that are usually integral to the backbone? So when abacavir, the 2 tenofovir formulations can't be used, what do you use? Here's what the guidelines recommend. There's a 2-drug regimen, dolutegravir and lamivudine, and that's actually getting a little bit of press right now as a regimen. It's a 2-drug regimen, so they're kind of pushing that that might be something in the future that might be recommended. As of right now, they just don't have the long-term studies to say use it for everybody. They're just waiting to see how the resistance testing long-term works out for that. So as of right now, they're not recommending it for everybody, but certainly if you have a patient that can't take some of those other medications, that's a viable option, and it's shown pretty good in the studies so far that it's efficacious. They just are going to wait until they get the long-term studies before they extrapolate that to everybody. And then there's a darunavir, ritonavir, plus raltegravir regimen, and you do have to make sure that the viral load is less than 100,000 copies and that the CD4 count is over 200 if you want to start that. Now, they did take the lopinavir regimen off of that stipulation for cases when you can't use those other medications, and that's just because it had more of a pill burden and poorer tolerability compared to those other two regimens. So some of the other recent changes to the recommendations, they took a boosted eltegravir regimen off, and it's just because the Cobestat, that is the boosting part of it, it has a lot of drug-drug interactions, so it's just better avoided if it at all possible can be. It has a little bit of a lower barrier of resistance than the two recommended regimens. So additional considerations if patients have comorbidities. So you always have to think about the whole patient. So you want to look at patients with liver disease, osteoporosis, if they have MAT, you want to look at these things when you're choosing their antiretroviral medications, because they can interact, and they can interact with the disease states as well. So for liver disease, it's not a contraindication, but you just want to make sure you watch the dosages and you check the references. For osteoporosis, if you can, you want to avoid the tenofovir, disoproxil, and you can use the other tenofovir formulation, and that's an option, or you can use bacavir for those patients if their osteoporosis is not controlled or if they have osteoporosis. For HIV-associated dementia or HAD, they recommend that you avoid efavirenz. And for psychiatric illnesses, efavirenz and rilpivirine, I'm sorry, I've got a cold, guys, you gotta bear with me. They can increase suicide rates, so you want to avoid those medications for those patients. For patients with MAT, efavirenz does decrease methadone levels. So not that they can't be used together, but if you can avoid it, it's probably best. And you certainly, if you're going to add that onto a patient on methadone, you want to be mindful of that because you don't want to induce withdrawal in a patient that's on MAT. So some other comorbidities that are pretty common, especially in our state, are cardiovascular disease and hyperlipidemia. So avoid abacavir and boosted PI regimens, except for some of those medications in that class. Now, the abacavir has some conflicting studies. It's not an absolute contraindication, but if you have a couple of options and abacavir is in one of them, you might lean towards one of the other ones. The studies aren't really conclusive, and like I said, it's not an absolute, but it's just something to keep in mind. For hyperlipidemia, you generally want to avoid the protease inhibitor regimens and efavirenz and the boosted elvategravir. Generally speaking, though, the integrase strand inhibitors are a good choice for a drug class if they have that issue. And this is one instance where the newer formulation of the tenofovir is not the better choice. So you want to go with the older, the tenofovir disoproxil formulation if the patient has hyperlipidemia. So for transgender, I'm sorry, I skipped. Sorry, you're right. So for hepatitis B, you want to pick a regimen that has one of the tenofovir formulations along with emtricitabine and lamivudine. So they have activity against both HIV and Hep B, but if you use either the lamivudine and the emtricitabine and don't combine it with another hepatitis B medication, then it can cause problems and resistance. So you want to be mindful of that as well. And also, if you are getting a patient already on a regimen and you're tweaking it, just be very careful if you're stopping any of these medications because you can start a Hep B flare, and that would be bad news bears for the patient. For transgender patients, we're starting to see this with some of our Medicaid requests, so I'm guessing you guys might be seeing this some in your practice. I know it's in the state, so I figured I would go over it because it's important to know. You have transgender patients, the gender-affirming hormones can cause some side effects. So they can cause hyperlipidemia, elevated cardiovascular risk, and osteopenia. And they just recommend that you don't tack on a medication for their HIV that's going to exacerbate those, because you don't want to give them a double whammy and something that's going to to kind of tip the scales for them. So you want to try to avoid regimens with those risks. And keep in mind too that some of the hormones they might be taking and the androgen blockers, they might not necessarily be getting them from a physician. They might be getting them from another source. So it might be worth asking if you have a complete med list on the patient. And if they've had a procedure such as a gonadectomy, that can actually increase antiretroviral related effects on the cardiovascular and bone health. So that's something to keep in mind as well. And also, still talking about the transgender patient, you want to also keep in mind that the hormone levels can be altered by some of the antiretroviral medications, which is not a significant problem if you're monitoring, but you might want to more closely monitor if you're the physician handling their hormone levels. And you want to make sure you titrate it to whatever the goal of therapy is, usually symptoms or outcomes. But they might need tweak depending upon which medication you pick. So just keep that in mind. And then monitor for the clinical effects and the hormone concentration. You just make adjustments as you would need to. So substance abuse disorder is something I know everybody sees because we see a lot of it too. So ongoing substance use is not a contraindication to starting them on HIV medication. So that's important to keep in mind. Now, ideally, we would like them to stop using illicit substances, but that's not always a possibility. We certainly don't need to stop their initiation on ART before we do that. You want to try to counsel them as much as possible on the importance of compliance, because that's of course going to improve it. And you want to pick a once daily single tablet regimen just to set them up for the best possible success they can have. So you want to pick something with low barrier or high barrier of resistance, low potential for drug-drug interactions when possible. So if they are using illicit substances and you know which ones they are, you can kind of counsel them a little bit better. And sometimes you know this information, sometimes you don't. If they're taking benzos, sometimes they might even be taking them for legitimate reasons and as directed, but it's important to counsel them, even if you know they're taking them recreationally, that it can increase the half-lives and concentrations. And the average patient isn't just going to know that off the top of their head. And sometimes if you do counsel people and bring it to their attention, they might take that in mind when they're using. So it's worth bringing up, I think. For the club drugs, they are metabolized by the CYP pathway, so they have lots of interactions, and there have been overdoses reported due to concurrent use with ART regimens and GHB and MDMA. So that's important to counsel them on if you happen to know that they're doing that. PDE5, I would have not thought that that would be a club drug, but apparently they're using it. That's going to be your sildenafil and medications like that. They're using it for those intended purposes, but then they're combining it with other club drugs for the recreational experience of it all. But they do lead to increased effects of the club drug taken. So that's something to keep in mind too, especially if you know that they're being prescribed the PDE4, you can kind of head that off and counsel them on that interaction. And we talked a little bit already about methadone with MAT and the efavirenz. That's important. If you have a patient you know is at risk for noncompliance, it could be due to drug use, due to the fact that they're just a busy person, or just due to the fact that they're kind of a forgetful person. These are some of the medications that are recommended for those patients. And the reason for that is that they have a higher barrier to resistance. So if they are a little bit non-compliant, they've got a better chance of success with these. Always stress non-compliance and the issues that that brings up with the patient, but sometimes it's just going to happen because it's going to happen. If you have a patient that has had previous virologic failure, so you want to perform the drug resistance testing while they're still on the failing regimen if you possibly can. If you're discontinuing it for a serious adverse effect, it might not be possible, but you want to try to do that if at all possible. If you've got 2 fully active agents, you preferably want to get 3, but if they have just a terrible resistance profile, you might be limited in your options. But they do recommend that you don't just add 1 new antiretroviral medication to an existing failing regimen because it promotes resistance. So you might get resistance to all 3 medications. So you just want to make sure that you don't just discontinue 1 and start another one. And if the patient has Hep B, you want to be mindful again of the ones that are active against Hep B, because you never want to stop those ones abruptly because you would induce a Hep B flare. And this one is just, since I'm going over updates, there's a new PrEP option coming out, and you've probably seen it in the news or commercials. It's really just a newer formulation of the tenofovir. So it's the emtricitabine with the tenofovir alafenamide. On the whole, if the patient's doing well on the existing formulation, there's not really a reason to switch. If they're healthy and they don't have comorbidities that would lead you to believe that it would be a problem, patients do very well on the existing one. And there's a generic coming out, I believe, in September 2020. It is a little bit far away, but that will be on the horizon. And if there's not a reason to switch somebody, you know, you never need to just jump to it, despite what the commercials say about how much better it is. Now, if they have a comorbidity that it makes sense, then absolutely. But the cost is relatively similar. I mean, I think the older formulation is a little bit cheaper right now, but again, it's just going to depend on insurance coverage. So I would just use coverage and cost as your guiding key, because whatever they can afford, they're going to be more compliant on generally. And of note, the newer regimen has been tested more in the MSM and transgender women population. If it's for a heterosexual woman, they recommend that you stay with the existing tenofovir disoproxil regimen. So keep in mind that if you're considering which one to select. And always check for drug interactions, because they can interact with some anticonvulsants and some Hep C meds. Again, it's not a reason you wouldn't start PrEP, but it's just something to keep in mind. And there's some good sources, and they go into much more detail than I went in today. If anybody has any further questions about that, those are some good links.
Awesome. Thank you so much.
Thank you.
You guys have any questions while I pull up some cases? All right. Thank you again, Angie. I'll let you know if any questions come in through the email. Oh, wait. Sure.
This is Gilfus here at the hub. Just to stress the point about the dolutegravir. Yeah, I walked in late. I don't know what the recommended initiation regimens that she listed are, but usually there's an integrase inhibitor on it, and dolutegravir is more commonly than not what people are on. The question often comes up in women of childbearing age: should they be switched off of that regimen due to the neural tube defect ? And that's really sort of been debunked on the most recent studies, which you probably talked about. So in general, I don't change people off of that regimen if they're a woman of childbearing age. The initial studies that looked like there was neural tube defect issues, they retried the patient, or actually they did further trials, and these were all in Africa, and they did not find an excess of neural tube defects. So the current consensus statements are sort of like, keep an eye out for problems, but don't necessarily have to avoid them. This has been a truism for antiretroviral therapies over the years. For a long time, Sostiva was like, that's Vavrins, was a no-no during pregnancy, and then it turned out that that's not true. And dolutegravir got this bad press about a year ago, and then the further trials said it wasn't an issue. So it's an area of unknown. I've had patients go through pregnancy on dolutegravir, and obviously that's the power of anecdote. They've done fine, but that doesn't mean at a population level there might be not some increased risk, but we don't know. We really just don't know. Is that about what you? Yeah.
Yep.
Some studies say yay, some say nay. So up to opinion.
Excellent.
And judgment.
Jenna, are you there? Are you able to hear me?
Yes, I'm here. My computer is not supporting all the functions of the Echo. I think it's my internet connection. So I'm just gonna chat by phone and try to watch the video sharing as long as my computer participates.
Sure thing. I just wanted to let you know I'm gonna share your case now so you can walk through it.
Okay. Okay, so this case was, Dr. Peters and Dr. Leonard both encouraged me to talk about this one just because it was a little unusual. This was a 6-year-old female that came into the clinic to see me mid-August for a follow-up from a walk-in clinic visit for a suspected septic arthritis. So the chief complaint on the visit in a week, I think it was like 3 days before she saw me in the office, was left, I don't remember honestly now if it was left or right knee pain, but she had a hot, tender effusion in one knee. The provider that saw her ordered a CBC, a CRP, and an ESR, which are listed there. Yeah, right there. So those were actually ordered at the visit before I saw her. Her white count was really minimally elevated with a little bit of a left shift, and her ESR and CRP were impressive for a 6-year-old. So I got to see her at the follow-up visit. Like I said, the provider, when he got the CBC back, was concerned about septic arthritis, so we started her on Augmentin. The mother brought her to her follow-up appointment and said, yeah, she didn't really like that medicine, so we gave her 1 dose and then threw it out. So we talked about it, and I had actually kind of pressed mom a little bit more for history of a rash or possible tick bites, because in the office when she saw me, the initial joint was fine. In 3 days, it was completely resolved. And mom said, oh yeah, the other leg is swollen and painful now because she's been hopping on that one for several days because of the first issue. So mom and I had to talk about how, kids don't get that kind of arthritis like 40-year-olds do, but not children. So, I told her, maybe we ought to look a little bit further into the history. We talked a little bit more about, she did have an unusual generalized rash. We looked at that note from that provider back in June, and it was just basically described as a diffuse light macular rash. Of course, hindsight's 20/20, and I'm asking mom about tick bites. Mom says, well, yeah, sure. I mean, it looked like a Lyme rash in the office. So we went ahead and did the Lyme titer, and which was positive. So started her on, I think I did 28 days. Yeah, 28 days of amoxicillin, 400 milligrams TID. And then I did a follow-up with her the 10th or 11th of September, and they said she was taking her medicine like it was prescribed and she was doing fine. So her particular case was kind of neat just because we thought, like I said, the first presentation was that of a septic joint. She didn't have any particular reason to have a septic joint. She'd had no recent injuries or illnesses, nothing like that. And I think it just took a little more digging. What really seemed to give it away for me, that made my suspicion increase for Lyme, was the resolution of the first joint effusion followed by a joint effusion in the opposite leg.
Awesome. Thank you so much, Jenna.
Yeah, sure.
Can I ask you guys first? Do you guys have any comments, thoughts?
That's an interesting case. I'm not sure I would have thought of Lyme. It's always helpful to hear somebody else's case to refresh what we should be thinking.
Absolutely.
This actually would be the second case we have had in our clinic. Well, I had a girl about a year ago presented just about the same way, and I thought it was arthritis. Right knee, left knee, wrists. So I sent her to pediatric rheumatology at Pittsburgh, and they checked her for Lyme. I didn't think about Lyme. I was like, this is not Lyme. This looks like arthritis. And it was Lyme disease.
Yeah.
They treated her, and so far as I know, I haven't seen her for a while, that it's all of her symptoms resolved.
Definitely.
Hey, Jenna, where's the physical location of your office? I can't remember.
I'm in Rock Cave, so it's about 15 miles south of Buchanan.
Okay, gotcha. Yeah.
So I will absolutely give credit where credit is due. This is one of those cases that you kind of luck into. I don't know in any other situation that I really would have considered Lyme either, but I had a family member with a fairly large joint effusion like the week before, and we just happened to discuss Lyme while we were being evaluated with that issue, and I don't know why, it was just on my radar. And I really, like I said, I don't think I would have thought anything of it if she had come back for the follow-up and the effusion was completely resolved and she didn't have an issue on the other side. But the second joint effusion, I thought, no, there's something else going on.
If you look at her testing, any question anyone has on her testing? Well, again, if you categorize Lyme in terms of stages, this is late stage Lyme.
That was actually one of my questions. Not so, I guess so much about testing, but with how long is it usually between when the tick bite occurs and when you get a joint manifestation? Because I think of it as a long time, and this seems relatively short.
Yeah, you can't. The months should come to mind. So the word months, yeah.
That's interesting.
Yeah.
Well, go ahead.
I agree with what you said. The time frame. You don't even know if that rash in June was it or not.
Oh, exactly. Yeah, no idea if that was Lyme, or, and that's exactly what I was going to say, or if that was a disseminated Lyme rash, which would have meant that her tick exposure could have been in April or May.
Yes.
But it's just neat because hindsight's 20/20. I never would have thought to even ask about a rash if she didn't have the second joint effusion, and the person that saw her with the rash wouldn't have thought to ask about a tick bite because it certainly wasn't classic.
The only thing you can say with confidence looking at her testing is that there has been quite a deal of time for her immune system to evolve a nice IgG response. So, this is well outside where you have IgM isolated positivity for like an migraines. She has whatever it was, 8 out of 10 bands for IgG positive, has a really impressive complement of Western blot bands. And the key words to think of for Lyme are oligoarthritis. Think of knee. Think of swelling, even above and beyond warmth and pain. So just a swollen joint, but of course they can be warm, but they don't have to be. I've been fooled in thinking that a joint may have been traumatized. In other words, the primary differential is like an ACL tear or some other damage to the joint. But keep in mind with oligoarthritis, especially that is self-resolving or episodic and perhaps fluctuating in the involved joint. Knees greater than ankles, greater than elbows. But her case is great. Oligo, large joint arthritis. So what if she didn't get treated? What expectations would you have? Eventually burn out. This probably would get better over time, but you probably expedited that by a factor of years by treating her. So good job. If she comes back and has more trouble, what should you do? So the algorithms for treatment of Lyme arthritis involve an escalating approach. So it's one of the few situations where our current guidance for Lyme will permit retreatment and escalation of treatment. So I'm going to give advice for an adult, but what we in general would do if somebody came in, if this was an adult patient, we'd give them a second round of doxy. And if they still have symptoms after that, you tend to escalate to IV Rocephin. So, we always are bad-mouthing the doctors who give patients more and more treatments for Lyme disease. In other words, you can only kill the bug once. And that's in general a true statement with the exception of Lyme arthritis, where you can have challenging persistence of the microbe in the synovium. And so you want to make sure that you treat these patients, treat them for long enough, and if they're having persistent symptoms, repeat or even escalate the treatment to IV therapy. there is a phenomenon known as antibiotic refractory Lyme, which is immunologically mediated. It does eventually burn out as well, but it could be somebody who's gone through IV ceftriaxone and still has a single large joint that gets intermittently swollen, has synovitis. And there is a role in those patients for disease-modifying agents like methotrexate, etc. So obviously not going to do that for a kid. But just know that Lyme comes in the infectious and then even in the post-infectious variety, where it seems to be more of an infectious arthritis and then more of an autoimmune arthritis. And all of that's in the differential, and you can't really categorize the patient without adequately treating them first. So treat, escalate, and then if you're still striking out, you know, get a rheumatologist to help you out with a DMARD, and then if all that goes by, they tend to burn out anyway over time. Again, looking at the natural history studies from the 70s and early 80s, over time, people get better. But this little girl's immune system was impressive. Her complement of Western blots is really profound. And Jenna, I can't think of a reason to repeat her Western blot testing because it'll stay positive and look scary. The only reason you'd ever test it is if there was a to prove that it's getting better over time, but I wouldn't even bother doing it. I really wouldn't. I would just say if she's symptomatically good, all is well.
There was a question about what age you would choose to treat Lyme with doxy instead of.
Oh man,
amoxicillin.
can't answer that question.
Okay.
I truly can't answer it. Because the Red Book, if you look up the Red Book right now, it's going to tell you can use doxy if it's going to be up to 14 days. But you didn't hear that advice from me. I can't give advice on kids, or I get struck by lightning by our lawyers. So, but I did read the Red Book recently, and for short courses they are amazingly permitting doxycycline use. But yeah, y'all have to read that yourselves. Not coming from me. But it's a great question. Thank you for asking it. I apologize we don't have a pediatric. I tried to get a pediatrician to come with us today, but they were busy in clinics.
It happens. Jenna, thank you so much for your case.
Yeah, great case.
Yeah, I'm going to pull up Dr.
Yeah, thanks very much.
Let me know if she does well or not well.
My suspicion is that she's going to be somebody who's going to be lost to follow up unless I insist they come back in. It was almost like pulling teeth to convince them to go get the Lyme titers drawn. She got hysterical in the office when I told mom we needed to draw labs, and mom was not really interested in having us draw them there. So then we had to make several phone calls within the next couple of days following that to make sure she actually went to get them drawn. So I will probably pull her back in. I think I'm going to see her for a well child at some point anyway, but you answered my question about whether or not we needed to repeat any serology, so that's helpful.
The serologies look great. I mean, they look terrible, but you can't look worse. So
Right.
They're going to look like that for a while. So truly, if there was no weird social stuff going on, this would be if I saw her back in follow-up and she was still having problems. If she was an adult, I would immediately go to IV therapeutics. Say it was a young kid coming in, a 20-year-old, and they failed around a doxy and they're still having symptoms. This is real Lyme, and this is the situation that you can potentially benefit by. So I'd probably, but in this scenario, it doesn't sound like a great situation for a PICC line and all that stuff. So.
Well, my big concern with her was medication compliance, simply because of the apparent lack of interest that the family seemed to have in her illness. And which is why I insisted on having her come back for a follow-up to make sure they were taking it. And I even went farther and called the pharmacy to make sure, the dates lined up with when they picked up the medicine and that kind of stuff. I learned, interestingly enough, and this might be something, it'll be something I remember for the future. I didn't realize that reconstituted liquid amoxicillin is only good for a very short period of time. So if you're going to do a lengthy treatment in a child that can use a chewable or swallow a capsule or whatever, the liquid's not the best, because the pharmacy split it up into two different dispensing dates, and the family was going to stop the antibiotic after they ran out of the first bottle, except they came back to the office. So we had to clarify that. But I think the next time, God forbid, I have to treat another pediatric Lyme arthritis, I'll use a chewable tablet of some sort.
Great advice. And
Plus, it tastes like crap anyways.
I'll taste that.
Yeah, it really does.
The other option would be a second generation Ceph, like or cefuroxime or something. I don't know if they taste any better. It's interesting. The kid didn't like Augmentin, but thought amoxicillin was okay. But,
I mean, I've heard that a lot historically from kids that I don't know what's in the Augmentin that tastes so terrible. I mean, I don't know, must be the clavulanic acid, but still, yeah, she seemed to do okay with the amoxicillin. I really didn't let them off the hook about how important it was to make sure she took her antibiotic either, because they were very flippant about it the first time I spoke with them when I saw them in the office on the first visit about, yeah, she didn't like it. We had a really lengthy talk about, you know, the ramifications of untreated septic arthritis. So.
Yeah. Thanks for being her advocate, no doubt. Yeah.
That's awesome. Thank you. All right, and Dr. Leonard, if you're ready, I can scroll through your case now.
Okay, I'm ready. Mine was just last week. Known patient of mine presented 1 week ago today, Thursday, with my smile looks funny, my eye won't close.
Wow.
And comes to the office. She's a 9-year-old biracial child. Mom is from Honduras. Dad is from Texas. Good family, neighbors to my in-laws. I've known them her whole life. She is my patient as well. And they live in Hacker Valley, West Virginia, so they live and play in the woods. So when she presented, clearly she could just about get her eye closed, but the left side of her mouth would not move when she smiled. It started with left eye feeling dry, progressed to, you know, I can't smile and I can't get my eye completely closed. So that's what brought him in to me on Thursday. The whole family had a URI. Everybody had a runny nose, stuffy nose, cough. So I really thought it was probably just viral, but went ahead and got the Lyme titers as well. And both their IgM and IgG were positive, and the Western blot's not back. So I don't have the breakdown yet. I put her on doxycycline twice a day based on the Red Book's new recommendation, which is a max of 200 a day and for only 14 days. So she'll get.
Thank you for reading that. Yes, yeah, that's what I was just implying. Thank you for yeah.
Yeah, that's not what I would have done if I hadn't looked. I'd have done 28 days. So they'll be compliant. And then so far, I mean, we talked to them, the family, and she's doing well. They have to open the doxy capsules, but that's no big deal.
Man, I'll be fascinated to see what her Western blot comes back.
Yeah, me too. I don't often get IgM and IgG. I'll get an IgM, and then in 4 weeks, the IgG will be negative. It'll be like 2 bands, 3 bands.
Yeah. So
in my last few cases.
Any questions we can answer on this case in particular? There was a. You know, great recognition. You know, if you're talking to Bell's palsy, your primary differentials are, you know, classically these have been considered herpes viruses, you know, VZV, HSV type stuff. And then obviously Lyme disease has taken over one of the most common causes of Bell's palsy, and it can be bilateral, it can be really scary. Remember, in the big phase of things, this is early disseminated. When deciding how long to treat somebody with isolated, or I should say with Bell's palsy, the question is it isolated Bell's palsy or is it Bell's palsy and meningitis?
Right.
And that's the clinical question, you know, do they have headache, fevers, stiff neck, etc.? And then you might think about treating longer, but isolated Bell's palsy, you sort of treat just like, short course. So well done. I applaud your approach on her. And I wouldn't doubt that it's just the IgM will be positive. On the Western blot, I bet you'll get, 3 out of 3 or 2 out of 3 IgMs positive and maybe 2 or 3 IgGs on the Western blot. It'd be interesting because, this is a fairly early manifestation, and you really have not had time for the good serologic conversion a lot of times. We've seen a ton of Bell's palsy this summer, and the IgMs have been really, really reliable. And the IgGs, sometimes you're just catching people too early. And if you treat them, you can abort seroconversion to IgG. And so remember, that doesn't mean your diagnosis was wrong. It just means your treatment was successful. And you killed the microbe before they developed a good complement of IgGs. So, but yeah, good case. I'm glad the Red Book updated this doxycycline permitted use up to 14 days in kids, because otherwise, this would have been something where classically we use cefuroxime or amoxicillin in a kid like this who just had isolated Bell's palsy. But it always made you a little worried that you weren't getting great CNS dosing, whereas doxy you're comfortable with it. So. But great case, man. Hey, by the way, Bell's palsy usually gets better fast. When I've treated people with this one, it's usually like 2 or 3 days, and they're getting way better. Did you see it or hear anything in follow-up, Dr. Leonard? Did he get better quickly?
I haven't. I heard she struggled taking her pills, and then we got her to open them up and use just a little bit of food. But we'll call today and figure out. Yeah, I just was kind of treating it like a typical Bell's palsy. Like it would still take quite a while to get better, but if they get better that quick, we'll get an update today. Then
a lot of the ones that it's not infrequent for adults to end up in the hospital with a stroke page for this, because the initial thought is somebody's having a stroke, and when we recognize it's Lyme and we get them on appropriate therapy, most of them leave the hospital already looking a whole lot more normal, like just in a day or two, which is great. Then again, I've also seen people come back 3 weeks in follow-up and still have obviously some asymmetry, but much better. So, but yeah, so treatment's a good idea. Again, compliments to you found this early. You got this in the early disseminated phase, and hopefully by treating it, you're aborting any late neuroradicular or arthritic complications. So yeah, good stuff. Scary, poor little kids. They gotta get some DEET and permethrin and all that stuff. They need to buy Xboxes and stop playing out in the woods. No more of this Americana.
I was going to say, it seems
Put
like
them in front of
Upshur County
Facebook.
kids are active.
It's active children. That's an anomaly. But
We can't hear you, Dr. Leonard.
Oh, I'm sorry. I was talking to my student about DEET and permethrin. Permethrin, really, I think, is supposed to be on the clothes mainly. Spray it, let it dry, and last 4, 5, 6 washings, and then DEET. For me, if it's not 100% DEET, it doesn't do anything. The American Academy of Pediatrics recommends 30% or less, but that's not going to do anything for you. So,
yeah, but it all works. DEET and permethrin and tick checks and all that stuff. But scary for kids. I took an oxoides off of my little boy this summer, and just sort of a little bit proud that at least they're outside playing. But you got to do those tick checks. So, but great cases, man. Those are awesome. I think both should have great outcomes.
Yeah, thank you
Dr.
guys a lot.
Gilsey?
Yeah.
Sorry.
Jenna, you go first, and then we'll take the next one.
I'm sorry. Abigail is singing and it's making it hard for me to know when it's okay to talk. I just had a quick question. We were chatting. I chatted with a colleague last week, I think, about, I was telling her about my Lyme case, and she had said, I've not read this, but she said she read somewhere about a prophylactic dose of doxy with a tick bite.
Mm-hmm. Yeah.
Can you tell me about that? Because I've not heard of that.
Yeah. It's for your patients that you see who are paranoid after Lyme, and this happens. We get people who obviously had a major manifestation of Lyme. That's probably why you've seen them. If they want to know what else they can do besides DEET and permethrin, if they have another recognized tick bite, you can give them a one-time 200 milligram dose of doxy.
So it's meant for people who have already had Lyme once?
Let me rephrase this. It's to be given to patients where we know that there's a lot of Lyme in that area. And by definition, if they've already had Lyme, we know that their Oxoides ticks carry Lyme. The CDC had put out this thing a few years ago where it had said, if a X percentage of your ticks have Borrelia species, you can consider, I think it was like 30%, if 30% or 20% of ticks in your area are infected with the Borrelia. Now, I don't know where you get that data. I have no idea. So what I personally have done is judge the geography where they live. If they come from southwestern PA, if they came from eastern West Virginia, honestly, y'all's counties due south of us, we've seen an insane amount of Lyme down in the Fairmont, Clarksburg, over into Taylor County, and basically you're seeing local Lyme, a lot of local Lyme. Your ticks have infection, your Oxoides ticks. So the criteria that the CDC wants to hold you to before they'll suggest you giving prophylactic doxy is they want you to know that it was an Oxoides tick. They want you to know that it was attached for a while. In other words, not crawling on you, but actually just a tick that's engorged. And that the local ticks have Lyme, or have Borrelia species. So that's kind of the criteria that they want you to meet. And if your patient meets those criteria, you can give them a prophylactic 200 milligram dose of doxy. In my patients who have Lyme and are outdoorsy people, I give them a prescription for doxy 200 milligrams and say, keep this on hand. If you find engorged tick and it's a Sunday afternoon, this will save you a trip to the urgent care center or whatever. So I've absolutely, because they've proven they have ticks on their farm that have Lyme, et cetera, et cetera. That's what I meant about using your patients that have Lyme. You can use this in patients who've not had Lyme before too, but you just have to be sure that they come from an area where Lyme is common. Does that make sense? I hope that makes sense. Yeah. Yeah.
We had one question in the chat, and then I want Jen to ask her question too. There was a question about, are you seeing RMSF? There was a case earlier this summer.
No, actually. So we've not seen much other tick-borne diseases, thankfully. But great question. Remember that the co-infection pathogens with the Oxoides tick are going to be the anaplasmosis and ehrlichiosis and babesia. I've not seen any babesia, 0. And I don't think we've had much ehrlichia anaplasmosis at WVU as referrals. It doesn't mean that they're not in the peripheral, just not coming to see us. The RMSF, remember, is going to come from the dog tick. And no, fortunately, I've not seen any, but I'm sure they're around. We tend to, as a state, be more of a anaplasmosis or ehrlichia state than RMSF. We've had a couple goofy rickettsial species that are not RMSF that come from mites, like something called rickettsial pox. We've had some cool other rickettsias. They're all doxy responsive, doesn't matter. So you get somebody comes in with speckles and a low white blood cell count and mild thrombocytopenia, mild liver enzyme abnormalities in the summer, and you don't know what they have, and their cultures are all negative. Consider doxy responsiveness, and consider giving them doxy as part of their approach if you're worried about an arthropod-borne goofy bug, one of the rickettsias or anaplasmosis or ehrlichia. But no, great question. I'm glad we've not seen much RMSF. Again, if you put all the tick-borne illnesses on a spectrum, the one you should fear more than any is RMSF, way more than Lyme, way more than any others, because RMSF kills people, whereas Lyme doesn't. And ehrlichia and anaplasmosis rarely do, unless you got something else wrong with you, like G6PD deficiency or like splenectomy or something. So yeah, thankfully, that's more Carolinas and Oklahoma and Arkansas and stuff like that. But, yeah.
And Jen, did you want to?
I just wanted to say thanks for those cases. It was really, really educational. And I had a friend who got Lyme this summer. She's in the Morgantown area, and she's a physician. She spoke to a physician friend of hers who, I don't know if he trained in Old Lyme, Connecticut, or at any rate, he had been in a really high Lyme disease area. And their advice to people kind of went one step beyond tick checks, or was in addition to tick checks, was after you've been outside, a hot soapy shower and scrub yourself with a washcloth. And that sort of gets rid of anything that could be there. I don't know why that's better than a tick check, but who can argue with a hot soapy shower after being outside is what I say. So anyway, that's what we do in our house now.
Absolutely. Great. All right, guys, we have like 1 minute. Do you guys have any questions, comments? I really appreciate both of the cases, and Angie, that was a great didactic. Good. Angie,
I have a question for Carmen. Had you seen any RMSF? Had you had a case this summer? Or,
This was the first one I had seen for a long time.
yeah.
But it probably actually came from out of state, but it was a resident here in Pendleton County. But he definitely had an embedded tick. He had fever, he had a rash, all that. Responded great to treatment, really didn't get all that sick, luckily.
But you know, it's there's so many of these darn rickettsial species, and the testing is fairly unrewarding. The response to doxy is rewarding. So, but yeah, so that's cool. Thanks for sharing that case. Love doxy responsive diseases. It's wonderful.
All right, and Joanna and friends, you guys had a question?
This is not Lyme disease related. I was just wondering if we'd heard anything else from about the Hep C meds coverage from Medicaid.
We have an announcement.
Yep, we do. So yesterday at the DUR board, they lifted the fibrosis requirement, and that's going to take effect October 1st. Yeah. And they have some additional criteria they're going to put up. They clamped down on a couple of other things. I don't think it's anything that's going to exclude a lot of patients, though. They're wanting people to be vaccinated for Hep A and Hep B, but as long as you start the vaccination series, they're fine with that. And then they want a consultation with a specialist. I think that was always part of the requirement, though. They want some contact information for who you consulted with, and I think that's just not really to be rigorous about it, but just to make sure it is an actual physician in the area and it's that you did consult. So you can just put Project ECHO and then who the physician you consulted with.
Dawn, are you still okay with us using your name in vain?
Like that.
It'll be fine.
Yeah, and they might ask for like an address or phone number, email or something, but I mean, if it's a physician we're pretty familiar with, that's fine. If it's a name we've never heard of, maybe include that information.
Is the sobriety restriction still there?
It is, for sure. Yeah, they're asking about that. They're wanting them, you just have to attest that to the best of your knowledge, they've abstained from the use of illicit drugs, excluding marijuana, and not abused alcohol for a minimum of 3 months. And then one other change was if they have a viral load, they're now asking for 2 just to make sure it's chronic.
That is fantastic. How'd you keep that to yourself for the whole hour?
The announcement to end the session.
Yeah.
That is great news. So no fibrosis requirement, just
Fibrosis requirement. They may even be a little bit easier on some of this going forward, but they're just waiting to see how much this breaks the budget. They don't want to make it too loose and then not be able to afford to treat all.
Oh my God, that is great. Thank you to anybody here who worked on that. That is tremendous.
A lot of work on it, but one of the things I want to make sure is we don't stop checking fibrosis though on patients. Remember that.
Sure.
Pretended for so long we're checking it for insurance reasons, but remember it's still really important to check those so that we can diagnosticate and also know who needs HCC monitoring and stuff like that. So let's make sure we don't stop checking. So good.
And another thing to include that's important, they are wanting that 12-week post-treatment SVR from here on out for at least the next year. So we'll be reaching out for that, but thank you for all the providers that have sent in the data thus far. We took it down to them Monday, and we discussed it yesterday at the meeting, and I think it significantly helped. So thank you guys for working with us for that, and for Rachel and for John and Kaylee and everybody who helped us compile some contact numbers. We really appreciate it.
Excellent, guys. Well, that's a great note to end the session. I'll reach out to all of you later. Thanks. Bye.